So this recording will go over cystic fibrosis. Cystic fibrosis is a little bit different than the respiratory disorders that we talked about so far because most of the disorders we talk about are very focused on the respiratory system. So they're either affecting the upper respiratory system, like with croup and epiglottitis. Asthma affects the little bronchioles. Cystic fibrosis, yes, affects the lungs, which we know is a priority for our patient, but it also affects many other body systems. So their GI tract, the different organs, reproductive system. So it's affecting more than just the lungs. So what is cystic fibrosis? It's a common genetic disease. The problem with cystic fibrosis, if you want to simplify it, is just that the patient has excess mucus. And sure, you can think about mucus in the lungs, which is our priority, but it's mucus, excess mucus throughout the whole body, which is going to plug up organs, plug up the reproductive tract, can cause bowel obstructions. So just excess mucus throughout the body. The mucus produced by the exocrine glands is abnormally thick, which causes obstruction of small passageways of organs. Cystic fibrosis is incurable, but there's been big progress in terms of the treatment of cystic fibrosis, even since your textbook was published. And we'll talk about the new med a little bit here in a minute, but there's a better outlook for the prognosis of these patients because of a new medication that's come to light within the past couple of years. In terms of etiology, risk factors, cystic fibrosis is transmitted as an autosomal recessive trait. That means both parents must carry the gene for the child to be effective. It's more prevalent with the white population. So manifestations, what are we going to see in the patient? In terms of the respiratory system, remember their whole respiratory system is going to be getting plugged up with that thick, excessive mucus. Things we're going to see, wheezing, dry, non-productive cough, can progress to wet cough with vomiting. If you Google like patient with cystic fibrosis in the morning, a lot of the videos are just a person coughing, gagging, just coughing up all the mucus that is sort of settled while they were sleeping. Repeated bouts of bronchiolitis, pneumonia, bronchitis. Obviously, if we have excessive mucus in our lungs, it's like a nice little breeding ground for bacteria. So that patient's going to be at increased risk for infections. Crackles, wheezing, diminished breath sounds, accessory muscle use, retractions, hypoxia. So all the things that go in with poor oxygenation, what sort of signs and symptoms are we going to see with our patient? Dyspnea, tachypnea, emphysema, atelectasis can develop as airways become more obstructed. Atelectasis is sometimes students think that's a collapsed lung, but it's actually the little alveoli of the lungs, which is where gas exchange occur, become collapsed or fluid filled, and they can't exchange gas like they normally should. Can affect the heart, leading to some heart failure, changes in the lungs as well. Clubbing would be seen late, so clubbing of the fingers, digital clubbing would be a late sign of low oxygen in a patient. So respiratory, we're plugged up with mucus. You're going to see signs and symptoms of someone that can't breathe properly. Also at increased risk for infections. Digestive system. So remember I said this is more than just a respiratory illness. Things you'll see with the digestive system. Steatorrhea. Rhea is runny. Steatorrhea is runny diarrhea, but it's considered to be a fatty diarrhea. So the patient's losing excessive fats in their stool. That's known as steatorrhea. And what it looks like is a frothy, really foul smelling stool that seems to be bulkier than normal. So excessive fat in the stool, also known as steatorrhea. Flatus as well, so gas. Malnutrition and growth failure. We talked about this mucus is going to be plugging up different organs, and that includes organs that secrete enzymes that aid in digestion and absorption of nutrients. So malnutrition, growth failure, they're going to be thin, underweight, really working hard to maintain their weight. You got pictures in your textbook of protuberant abdomen, sort of sticking out, barrel chest, rounded, wasted buttocks, and thin extremities are common. We're going to be deficient in fat-soluble vitamins. You're going to want to recognize your fat-soluble vitamins if you don't recognize them now. ADEK. I know kids or students in the past had used the saying all kids eat donuts to remember AKED, but you want to recognize that we're going to be deficient in these fat-soluble vitamins. Why? Because the enzymes that help us absorb fat aren't going to be able to get where they need to get in order to absorb the fat. So the fat is going to be lost in the stool. And since we can't absorb the fat, we're also not going to be absorbing fat-soluble vitamins. This is a big one. First sign that a patient might have cystic fibrosis. You want to be familiar with this. Meconium ileus in the neonate is the earliest clinical manifestation. So what does that mean? An ileus, hopefully you've heard of that, paralytic ileus, hopefully, right? So paralytic ileus, the bowels aren't working like they should, right? So everything slows down, bowels are hypoactive, you might not hear anything at all, they're not passing flatus, not passing any stool. When you see it with meconium in front of it, I mentioned with a neonate being a newborn, we're saying that their very first bowel movement, meconium would be their first stool, their first bowel movement, isn't passing. So first thing you might see in a newly born fresh neonate that could be indicative of cystic fibrosis would be meconium ileus, or failure to pass their meconium, failure to have their first BM. Other things, intestinal obstruction, intestinal issues. The intestines are going to get filled up, can get plugged up with mucus and cause problem as well. Liver disease, diabetes, we're saying the organs themselves, the liver, the pancreas, can get filled up with mucus, not function properly, and cause problems for the patient. Exocrine glands. Abnormally high concentrations of sodium and chloride in sweat are seen early in cystic fibrosis. Sometimes the parent will say that the child tastes salty when they kiss them. So excessive concentrations of sodium and chloride in sweat. There's a high risk for electrolyte imbalance, especially when it's hot out. They're prone to hyponatremia and hypochloremia, as well as dehydration, dry mouth, and also increased susceptibility to infection. Finally, the reproductive tract, you're going to see delayed development of secondary sexual characteristics. Patient may have a difficult time becoming pregnant due to thick cervical mucus, but that doesn't mean it's totally impossible. But we're going to have a difficult time with conception with a female who has cystic fibrosis and a male as well if they have cystic fibrosis. Labs then, what are we going to do? How are we going to know our patient has cystic fibrosis? Things we're going to watch for are bowel obstruction or meconium ileus at birth. Clinical signs, so any other, the patient's tasting salty, there's some respiratory issues going on, things of that sort. Close family history of cystic fibrosis, we said that it has a genetic component, so we're going to be following up on that. And then there's also testing that can be done. For our purposes, we want to know that the child would have a positive sweat test, and that's when they're going to go in and assess the levels of sodium and chloride in the sweat. You don't have to memorize the numbers. You just want to know a positive sweat test. And of course, DNA testing would tell us if the child has the markers for cystic fibrosis. Other things we can do, fecal fat analysis. We know that if they're not absorbing fat, they're going to have more in their stool. This is another thing we do to see how well our treatment's doing for our patient. Because if we're giving the patient things that are going to help with fat absorption, but they're still having steatorrhea, those fatty stools, that's going to tell us either our treatment's not prescribed properly, maybe it needs to be tweaked a little bit, or the patient's not compliant. Going to watch liver function tests, blood glucose, get a chest x-ray, sputum culture, and also monitor lung function with pulmonary function tests. In terms of priority problems, our priorities, ABCs, so impaired gas exchange, the respiratory issues are going to be our priority, but since it's affecting multiple organ systems, there's going to be some other things we need to address as well. In terms of therapy, it's individualized for each child and is aimed at preventing and treating pulmonary infections, maintaining oxygenation status, maintaining optimal nutrition status, and promoting psychological adjustment as well. For respiratory issues, remember that respiratory infection is a big problem. for patients with cystic fibrosis. So the goal is to relieve any airway obstruction by mobilizing secretions. That means making it so they can cough out that mucus, and treat infections with antibiotics. I had a friend who had a child with cystic fibrosis, and she actually had a port because she frequently needed IV antibiotics to treat her lung infections. So things for airway clearance. How can we help the patient cough up those secretions? One thing you may have heard of is physiotherapy chest percussions. So that could either be a person actually basically pounding on the patient's back to try and loosen those secretions. There's also vests that the patient can wear. Maybe you've seen that in the clinical setting, that basically do some shaking. So like the pounding that a person would do, a vest actually does it for them, and that helps to loosen the secretions so that coughs can effectively bring up the secretions. Other things are like vibratory mechanisms that the patient breathe and inhale, exhale into, that has a little vibratory effect that can shake up and loosen mucus so it's easier to cough up. Let's see here. Other things would be a hypertonic saline nebulizer. So it'd have a high concentration of sodium to help loosen up those secretions so the patient can cough them up. Exercise is important for the patient as well. So they're going to continue with exercising. Antibiotics, of course, if we have an infection, would be important. Looking here, what else do we have here? Corticosteroids can also be given to decrease inflammation. And a new med that I talked about your book doesn't mention is Trikafta, Trikafta. You don't have to know it for testing purposes, but I want you to be familiar that there's a new sort of miracle med on the market that is improving patients' lives and those with cystic fibrosis. And Trikafta is available for patients ages 2 years of age and older that have a specific genetic mutation making the medicine effective for it. So for those who do get benefits from Trikafta, it really helps with their lung function and just their livelihood. For digestive problems, we're worried about malnutrition. Children with cystic fibrosis are managed with high calorie, high protein diets and pancreatic enzyme replacement therapy, fat soluble vitamin supplements, and if nutritional problems are severe, they can get gastrostomy feedings or TPN as well. Fats are not restricted unless diarrhea cannot be controlled by increasing pancreatic enzymes. So let's talk about them, these dietary managements. So we said high calorie, high protein diet. Got it. Pancreatic enzyme replacement therapy. So they're going to be taking pills every time they eat, because in a healthy person, whether you eat a snack or a meal, the pancreas secretes enzymes to help absorb fats. If the pancreas is plugged up, not working properly, the patient can take supplemental pancreatic enzyme replacement therapy. They'd have to take it with meals and even snacks just to sort of mimic what the body would naturally do if the pancreas was working properly. Secondly, fat-soluble vitamin supplements. We know we're having problems absorbing fat, so we're having problems absorbing those fat-soluble vitamins. And if you remember, they are AKED, all kids eat donuts. So we'll take supplemental vitamins for those. So our goals for the patient with cystic fibrosis are that they can keep their airway clear, they do not have impaired gas exchange, they're free from infection, they maintain their sort of nutritional status, and that their psychosocial needs are being met as well.